The next part of the nursing process is to plan our care or generate solutions. This is the time we get to make our goals for care with our patient. Here's the picture of the clinical judgment model again. If you notice, this section, planning, generating solutions, is in purple. They're the same step. This is where we come up with the outcomes and the goals of care with our patient. These outcomes and goals are really the patient outcomes we expect to see when we work to fix the priority problem we determined for our patient. If you notice, I said patient. Our outcomes and goals are all about the person we are caring for, made for that person, with input from that person. This is 100% person-centered care. We must keep the person, their interests, and preferences in the middle of every aspect of planning our outcome and goals. The more active the person is with planning their outcomes and goals, the higher chance of success we have to help them achieve these goals. In very simple terms, we can think of outcomes and goals as the things I must observe in my patient to demonstrate that the problem has been resolved. The outcomes and goals come from our PES statement, so they're directly related to the priority problem. They give us our direction for planning our interventions and give us our criteria for evaluating the patient's progress. In addition, remember all of those legal entities we discussed in professionalism, TJC and policies and procedures and the law? Well, they all say we have to have outcomes and goals. And FYI, NCSBN and the NCLEX do not require outcomes and goals, but those legal bodies do. An outcome is a broad statement describing the desired change in condition we want to see with our patient. The outcome should be the opposite of whatever our priority problem is. For example, our pneumonia patient with the ineffective airway clearance because he has so much secretions he can't cough it out, if his problem is he can't effectively clear his airway, the opposite of that is he will be able to effectively clear his airway. So our outcome should be that the patient will be able to effectively clear his airway. Let's try a patient having a lot of acute pain. If our priority problem is acute pain, the opposite of that would be less pain or no pain. So our outcome would be that the patient reports a decrease in pain levels or even no pain. I like to think of the outcome as the overarching goal. It's the biggest goal that the patient has at the time. Goals are a little different. Goals are little stepping stones to reach the outcome. Typically, goals are related to the data we collected in the recognize and cue stage that we use as evidenced by in our PES statement. Let's use acute pain. Our outcome is our patient reports a decrease in pain levels, but our patient evidenced his pain by crying, having a high heart rate, and refusing to ambulate. Each of those pieces of evidence should be a goal. One goal could be the patient won't cry. Another goal could be that the heart rate is within normal limits. And the last goal could be that the patient ambulates. All of these little goals affect the outcome because if the patient has improvements in these little goals, then he's probably having decreased pain. When we need to identify our outcomes and goals, we need to keep the bigger picture in mind, getting our patient back to a place of health and back to where they came from. If our patient's in the hospital, we're focused on what the patient needs to do to achieve being discharged from the hospital. That's always our end focus. We actually start planning for discharge as soon as the patient is admitted. This means we may have an outcome that's a little longer time frame in mind, like within a week or by discharge, and our goals may have more short-term time frames, like within 60 minutes of receiving pain medications, or by the end of the shift, or within 24 hours. Remember that the outcomes and goals are what the patient will achieve, not what the nurse will do. The outcomes and goals are person-centered, culturally appropriate, and support the total treatment plan for the patient. This means we are not setting outcomes and goals that go against what the medical care is trying to achieve. Our interventions that we'll talk about in the next PowerPoint directly relate back to our outcomes and goals. Everything nurses do is goal-directed. We always do things for a purpose, and that purpose is to fix our patient's priority problem. When we write out our outcomes and goals, we must ensure that they meet certain criteria to be of good quality. The criteria we use can either be found using the RUMBA acronym or the SMART acronym. RUMBA stands for relevant. Does our outcome or goal match the current situation? Understandable. Does our outcome or goal clearly state the who, what, where, when, and why? Measurable. How will it be determined if the goal is achieved or if it was not? Believable. Is it possible for the patient to achieve this? And lastly, achievable. The patient has the skills, attitude, and drive to accomplish the outcome or goal. Personally, I prefer the SMART acronym because that's what I was taught. You can choose. It does not matter what you use. SMART stands for specific. Did we list the who, what, where, when, and why? Measurable. How will it be determined if the outcome or goal is achieved? Attainable. The patient has the attitude, skills, and drive to meet this goal. Realistic. Is it possible to achieve this outcome or goal? And time bound. There's a time set for our accomplishment. If you notice, Rumba and SMART are basically stating the same things, so it doesn't matter which you use. Using either of them ensures that the outcome of the goal is patient-specific. So why do we use Rumba or SMART? Well, when we use Rumba or SMART to create outcomes and goals, we're ensuring that our outcomes and goals are written in a way that anyone who works after us can say for sure, yes, the goal is met, or no, it's not. We're ensuring that the outcomes and goals make sense for our patient. Let's take an example of a patient with a newly amputated left leg using SMART. I can easily write a goal for this patient to ambulate in the hallway using SMART. The patient will ambulate 1 lap around nursing unit using walker within 24 hours of surgery. Is this goal specific? Yes, it clearly lists who will do what. The patient will ambulate. Is it measurable? Yes, 1 lap around the nursing unit using a walker is very easily measurable. Is it attainable? Possibly. It can be done, but is it realistic to think that someone who just had their leg amputated will be up and ambulating around the nursing unit within 24 hours? Probably not. Is it goal time bound? Yeah, we have 24 hours there. So it's pretty smart, but it's not the best. I bet if we change that time frame to be by discharge instead of 24 hours, it would be a lot more attainable and realistic. Now let's look at the same original goal with Rumba. Is the goal relevant? Yes, ambulating is very important after any surgery, so it is relevant. Is it understandable? Yes, it is. Is it measurable? Absolutely. Is it believable? Maybe not within 24 hours. Is it achievable? Probably not within 24 hours. But if we change that time frame to be within 1 week or by discharge, then it absolutely meets the Rumba criteria. So when we write out our outcomes and goals, we need to make sure that we can say yes to every category, whether it's Rumba or SMART, before we type that outcome into our chart. There are several errors nurses can make when writing outcomes and goals. The most common error is using verbs that are not observable or measurable. The word understand sounds great, but how do you measure understanding? Understanding is very vague and does not have any way to say yes or no that the patient actually understood something. Verbs like demonstrate or list are good because we can watch the patient demonstrate and see if they're doing something correct or not, and we can watch or listen to them make a list. We also want to ensure that there's only one patient behavior for the outcome and the goals. We do not want to write that the patient will demonstrate and list the steps for hand washing. This should be 2 separate goals. Demonstrate is one goal and list is a separate goal. Another error we do not want to make is writing vague outcomes or goals. Remember, our outcomes and goals need to be very specific. If there's any vagueness or any questioning at all to what the outcome or goal is measuring, then we will not be able to definitively say, yes, they met their goal, or no, they did not. This is the end of the planning and outcome stage. Next, you're going to be going to the next PowerPoint of the series where we're going to talk about our interventions.